I think we'll go ahead and start. It's 7:04. I want to thank everyone for participating this morning, this afternoon, this evening. I especially want to thank our presenters today who will be talking about probably one of the most important systemic therapies for breast cancer, and one that's very available, and that is endocrine therapy. I'm going to introduce both speakers now, and then I'll just have them continue. I'll have the second speaker go right after the first, and then we'll have a discussion at the end. So our first speaker this morning is Dr. Morgan. She's an assistant professor in the Department of Hematology, Oncology, and Transplantation at the University of Minnesota. She is a medical oncologist who cares for patients with skin cancer and breast cancers. I've had the opportunity of working with Dr. Morgan on multiple patients. She's worked a lot with building oncology systems and cancer research in Rwanda, Malawi, Kenya, and previously served as the oncology field director for Indiana University's partnership in Kenya, known as EMPATH. She's previously completed a Fogarty Global Health Fellowship, has been awarded numerous grants for breast cancer research in East Africa, including a Cancer Women Who Conquer Cancer Young Investigator Award. So Dr. Morgan will be starting. Our second speaker is Dr. Fadelu, who is an MD PhD and is the Deputy Director of the Center of Global Health in the Division of Population Sciences at Dana-Farber Cancer Institute in Boston. He's an assistant professor of medicine at Harvard Medical School. He has an extensive clinical and research focus in global breast cancer. He is engaged in implementation science research projects in both Rwanda and Haiti to address the global inequities in breast cancer care. His work has been funded by a Harvard Catalyst Grant, a Conquer Cancer Foundation, Breast Cancer Research Foundation, and numerous other sources. So we are pleased to have two expert speakers today, and I will have Dr. Morgan start us off.
Thank you, Dr. Tuttle. So I'm going to start off talking about adjuvant endocrine therapy for women with hormone receptor positive breast cancer. And please put any questions in the chat. We'll get to them at the questions or thoughts or experiences in the chat, and we will get to them at the end. So I first want to talk a little bit about the definitions of endocrine therapy. We'll get into the evidence behind the benefits, really how long women should be on endocrine therapy, and then really the flip side are the side effects and the challenges that Dr. Fadelu will get more into, and then the general recommendations for pre- and postmenopausal women. So I think it's most important to talk about when adjuvant endocrine therapy is going to happen in the treatment continuum. When we have women with stage 1 to 3 hormone receptor positive breast cancer, we are usually talking about endocrine therapy after they've completed definitive therapy. And for many women, this could be that they've received quite a bit of therapy thus far. Many of them have been through surgery, 6 months of chemotherapy before or after radiation. And so this is the end of their journey, but there are still many years of endocrine therapy to think about. And when we think about endocrine therapy, this is really an umbrella term for any treatments that block the hormone receptor positive tumor growth by suppressing estrogen production, or it could interfere with estrogen signaling. There are numerous mechanisms that you can see over here to the right. And our big focuses here are aromatase inhibitors and tamoxifen. Aromatase inhibitors work by blocking aromatase, which transforms androgens into estrogens, and most of this happens outside of the ovaries, which is why postmenopausal women take aromatase inhibitors. Tamoxifen, however, really works in a different way in that it selectively modulates these co-activators and co-suppressors of estrogen. So that's more in kind of the modulating fashion. And then we have GnRH agonists, so drugs like Lupron or Zoladex that really directly suppress the pituitary hormones and thus ovarian production. You would also achieve this through removal or ablation of the ovaries as well. And one thing we know is that patients who are estrogen or progesterone receptor positive benefit from these therapies. And their benefit is proportional to the percentage of estrogen receptors they have. But we know that even women with low amounts of estrogen receptor, maybe 1 to 10%, still benefit from therapy. And really the biggest factor that goes into what endocrine therapy we might select for women is what is their menopausal status. And you can use a few different criteria. The first one being if you're 60 or older, the likelihood that you are in menopause is very high, and that alone can be a criteria. Obviously, if someone has already had both of their ovaries removed, they are thought to be in menopause. Then there are kind of a few other conditional circumstances. So women who are less than 60, but have had amenorrhea, say for 12 months or more, and they've never had any treatment like chemo or endocrine therapy to disrupt that, they would also be considered menopausal. And then women who are less than 60 and have had chemotherapy-induced amenorrhea for 12 months, if they have FSH and estradiol in the postmenopausal range, they can also be considered postmenopausal. And those labs would be a high FSH and a low estradiol. If you have that available to you, you could always test that. If not, you can use clinical criteria then. And really, for the longest time, the studies really looked at 5 years of endocrine therapy and the outcomes. And the evidence was very strong that if you give 5 years of endocrine therapy to women with stage 1 to 3 hormone receptor positive breast cancer, it significantly reduces the risk of recurrence, contralateral breast cancer, and then breast cancer and all-cause mortality. And probably in one of the biggest studies that we see is that tamoxifen reduces the risk of breast cancer recurrence by 50% in the first 5 years. And you can see that over here to the right. We also see that rates of breast cancer deaths were 30% lower with tamoxifen compared to just observation. So we know that there is an immense benefit to endocrine therapy. And I think across the board, the number really ranges from 30 to 50% reduction in risk of recurrence. And that's what I tell a lot of my patients. One of the things that's very important is that postmenopausal women do derive additional benefit from aromatase inhibitors over tamoxifen. And we see that they have 1/3 fewer recurrences and reduced breast cancer deaths. And so recommending an aromatase inhibitor first to postmenopausal women has its benefits. And so the challenge is that while that data has been really robust for 5 years of adjuvant endocrine therapy, I think the challenge is that women who have hormone receptor positive breast cancer have a persistent risk of recurrence. And this study was published in the New England Journal. And I think this is a great teaching point for our trainees when they come to clinic, is that this risk is very persistent. So what this study looked at is women who've received 5 years of adjuvant endocrine therapy. What is their risk at 10 years, at 15 years, at 20 years? And if you look, say by T-staged here up on the left, at 20, this risk just continues to go up. even after 5 years of endocrine therapy. This is in T1 high end stage. They still have a, N4 to N9. They still have a 34% risk of distant recurrence. And I think this, and if you look here, T2, N4 to N9, they have a 41% risk of distant recurrence at 20 years. And this, and even women who have, and if you look up here to the top right, women who have N0 disease, T1 to T4 N0 disease, still at 20 years, they have a 22% risk of recurrence. And I think because of this persistence of recurrence, distant recurrence especially, there were a lot of studies that have looked at extended endocrine therapy for good reason. And so some of the first data for extending endocrine therapy beyond 5 years was with the 10-year tamoxifen studies. And this was shown to reduce breast cancer recurrence. There was a relative risk. The relative risk was 0.75. It also reduced breast cancer and all-cause mortality when you extend it to 10 years. And so this can be an option, especially if many of you are seeing high-risk women. So women really with high-risk clinical features or molecular features, stage 3 patients, with this last chart here, we see that, especially with women with node-positive disease, they really have a very strong, persistent risk that continues to go up after 5 years of endocrine therapy. And so I think consideration for extended endocrine therapy, if you are seeing a lot of women with locally advanced disease, is a thought. And there are a lot of things that go into how to select endocrine therapy and what are the challenges. So the main thing are the side effects of endocrine therapy. While most of them are a pill that you take every day, they are not easy to take. Broadly, tamoxifen and aromatase inhibitors have symptoms of hot flashes and mood changes, hair thinning, vaginal dryness. And then aromatase inhibitors have the specific side effects of joint pain, mainly of the small joints, and bone thinning, causing osteopenia and osteoporosis. Tamoxifen doesn't have the joint pain and the bone thinning like aromatase inhibitors, which can be quite bothersome, but there are a few severe side effects that need to be monitored for, like blood clot, cataracts, and the 1% per year risk of uterine cancer. And because of all of these side effects, the discontinuation rate is high, and there are a variety of studies across the globe that show these are likely at least 30 to 35%, some say higher. And there's a significant proportion of patients who never initiate endocrine therapy. Some studies quote over 20% of people just never do. And this may be because of access. This may be because of what is recommended by their physician. Maybe it's not thought to be important. Maybe a variety of things. Maybe patients have heard about the side effects of them and do not want to try them. But there are many reasons for that. And then adherence rates still remain variable, really, across the world, across the globe. And there's a lot of limited data from LMICs. I think this is where we need a lot more data on how women are taking endocrine therapy in a variety of different settings. And we know that adherence drops if you add multiple therapies. So women who are on tamoxifen and ovarian suppression, we know that their side effects are higher and their adherence rates go down. And that women who take endocrine therapy after 5 years, their adherence drops after that as well. So what are the recommendations for postmenopausal women? And I took these recommendations, for what I use are the harmonized guidelines for sub-Saharan Africa. the NCCN guidelines for harmonized guidelines for sub-Saharan Africa for breast cancer. I think these are really good for considering what is helpful in certain situations. So the general recommendation for a postmenopausal woman is to take an aromatase inhibitor for 5 years. The other option is that you could split between an aromatase inhibitor and tamoxifen. And tamoxifen can be quite a bit easier to tolerate, and the discontinuation rates are lower on it. So that can help women to stay on therapy if they struggle with aromatase inhibitors. And then the other options would be taking tamoxifen for 5 years. We know that's slightly lower efficacy, but it's better than not taking anything. So tamoxifen for 5 years is an option in women who don't tolerate aromatase inhibitors. And then considering an additional 5 years of tamoxifen or aromatase inhibitors if you have women who are high clinical risk, node-positive disease, stage 3 disease, especially, and if you have genomics, or high-grade tumors, those would be reasons to be considering extending beyond 5 years. I did postmenopausal women first because it's more straightforward. Premenopausal women can get a little more complex because they have more options. So the general recommendation for premenopausal women is 5 years of tamoxifen. And even the harmonized guidelines for sub-Saharan Africa state plus or minus ovarian suppression or ablation. And the reason for this is the studies to the right are called the SOFT and TEX trial studies, where they looked at adding ovarian suppression to endocrine therapy for premenopausal women. And there was an improved disease-free survival, namely 85 versus 78% at 8 years. This has not translated to a survival benefit yet, though there has been a trend in some studies. But as many of you can see, the risk of distant recurrence in hormone receptor positive breast cancer, that risk is long, out to 20 years. So this study will have to be followed for a long time before it may realize a survival benefit. But because of this improvement in disease-free survival, ovarian suppression has been recommended. And we see that women benefited across the board, regardless of T stage, N stage, and especially women with stage 3 disease benefit. So you can think about doing ovarian suppression with drugs, injections, or surgically removing their ovaries, though that is a very complex discussion with the patient. The other option is 5 years of an aromatase inhibitor with ovarian suppression. And premenopausal women have to have their ovaries suppressed before they go on an aromatase inhibitor. That's very important. Otherwise, you could spike the estrogen levels because you're blocking the conversion of androgens to estrogens outside of the ovaries. So premenopausal women cannot go on an aromatase inhibitor unless their ovaries are already suppressed. And so when I think about high risk premenopausal women, we think about them going on tamoxifen and thinking about getting their ovaries out or suppressed for a period of 5 years. If women don't want to have ovarian suppression or removal, then I think about doing 10 years of tamoxifen. Those things that can help reduce the risk, especially if you have a woman with, for example, stage 3 disease who's premenopausal. Commonly given in high-income countries, like in my clinic in the US, are CDK4/6 inhibitors because there is an improved disease-free survival. So these are the drugs ribociclib, abemaciclib. Again, these have not shown overall survival benefit yet. and we will await to see that. But these drugs are very expensive. And like I said, we have not yet seen a survival benefit. But I just mentioned these in case people have access or patients specifically asked about them. But the cost is the major concern. Um, and so really when you think about premenopausal women and endocrine therapy, you need to think about, okay, what is their menopausal status, first of all? What are the side effects? How are you going to manage the side effects? What is the drug supply and how frequently are women going to be having access to their drugs? Are they going to have to come every month to get them? Can they get a 90-day supply? Because these are drugs that could be given for 5 or 10 years. So I think the supply really matters. And then issues around chronic medication use. It's challenging to take a pill every day for anyone. And so how to help with adherence is an important part of that. And then for premenopausal women, really we have to think about fertility as a major concern and whether women want to conceive in the future. And we need to involve their patients, their families, their caregivers, so people understand the benefits and the side effects that may come from endocrine therapy. One thing I do want to mention is the positive trial. So for women who desire future fertility, there is a study that shows that interruption of endocrine therapy after 18 to 30 months to conceive didn't result in any increased breast cancer events at 3 years. This was short follow-up. And I would mention that most women had pretty early stage disease, 93% were stage 1 or 2. But this is a very common question we get is, can I have another child? And I think, again, this will have to be balanced with how high risk their disease is. A stage 1 or 2 women, we do see that they can safely conceive and then resume endocrine therapy. So overall, we know that endocrine therapy has significant benefits, and these should be discussed with women who have localized hormone receptor positive breast cancer. Which endocrine therapy we select depends on their menopausal status and how high risk they are and their risk of recurrence. Side effects are significant but can be managed. And then premenopausal women really have a lot of factors to consider when they're choosing their endocrine therapy and thinking about their fertility. So thank you, everyone. I will turn it over to Dr. Fadelu now.
Okay, thank you. Can you all hear me okay? Yes. Yes.
Yes.
Perfect. Thank you, Jenny. So I'll be talking about strategies for optimizing endocrine therapy used for breast cancer in Rwanda, and partly talking about some strategies for improving diagnostic capacity as well as strategies for improving medication adherence. So here's a brief outline of what I will be talking about. I'll go briefly through some slides on global breast cancer disparities, some data that we have about endocrine therapy use in Rwanda, some information about improving biomarker analysis, and then some examples of some adherence interventions and some future directions. Here are my disclosures. I think I'm preaching to the choir, so I'm sure a lot of you are aware that the incidence of breast cancer is rising globally, and more so in lower middle income countries. And the incidence rates are expected to almost double in Africa over a 20-year period from 2020 to 2040. There are global breast cancer disparities. I'm also preaching to the choir here, but I think just having a look at some of the numbers can be helpful in framing the importance of endocrine therapy. So the mortality to incidence ratio, meaning the number of patients in the population who die from the disease over the number of people who are diagnosed with the disease, is 14% in 0.14 in the US compared to 53% in Rwanda. And the number in Rwanda is quite similar to the number in many sub-Saharan African countries. I think we all know some of the reasons why this is the case. So differences in the rates of metastatic and non-metastatic disease. So while in the US only 6% of people have metastatic disease at diagnosis, in many parts of Africa, the numbers can be between 30 and 50% and even more in some places. It's not just differences in stage that account for the disparities in outcome. This was an interesting study across a multinational cohort across multiple countries in Africa, where they reported 3-year overall survival outcomes. And in this graph, the blue part of the graph were the overall survival outcomes that were reported within the population. And they modeled reasons why I guess they modeled how survival outcomes could improve based on some specific reasons. So the first, the green part was if there was downstaging, how much would the survival outcomes increase? The red part is if there was improved access and adherence to treatment, and the yellow part is about social inequities. So just giving you a sense that it's not just stage, but also access and adherence to treatment also plays into this. I think I'll skip this slide. And sort of delve into the specifics of what we'll be talking about, which is endocrine therapy use in Rwanda. So here's the context of the setting that some of the work I'll be describing took place. So this is a Butaro Cancer Center of Excellence, which is in northern Rwanda. It was established in 2012. Originally was utilizing a task-shifted model because there were not a lot of trained oncologists or oncology nurses, so general practitioners and pediatricians and internists were delivering care. It was the first public facility for comprehensive cancer care in Rwanda, and over the years has expanded and is now a teaching hospital as of 2024. So I'll pause here and sort of talk about the concept of adherence more broadly, because I think many times when we speak about adherence, we may not necessarily have a common understanding of what we're talking about, and the different aspects and different components to this idea of adherence. So I think Dr. Morgan mentioned some of this in her previous talk. So the sort of like three main parts to this concept of adherence. One being, was the treatment actually initiated? And two being, how long was the treatment? How long did the patient persist in taking the treatment? I think that concept sort of comes along with the idea of persistence, or did they discontinue the medication earlier than the intended duration? As was presented previously, in this case, the intended duration is somewhere between 5 to 10 years. So how long was the medication taken for? And sometimes someone might take the medication for the entire period of time, but is not necessarily taking the medication consistently. So that comes, the way we describe that is adherence implementation. So is a person taking the medication how it's supposed to be taken? Are they taking it daily? Are there interruptions in between? Or, and sort of understanding, the process of what is actually happening with the taking of the medication. So I think those concepts are important in measuring adherence. And I think when someone says that they measure adherence, it's important to say what part of this they're actually talking about. So, this was some measurements we did in the Rwandan context on adherence. We had a retrospective cohort of 201 patients. So this cohort was formed in 2020, 2021. of 201 patients with non-metastatic breast cancer. Um, and so in order for you to start endocrine therapy or know that you qualify for endocrine therapy, you do need to get pathologic testing. So in our cohort, 20 of those patients did not have ER/PR testing on their diagnostic sample. And of the folks who had ER/PR testing, 113 of them were ER and or PR positive. So we measured some adherence measures within this population. So 22% of people never initiated treatment. Of those who initiated treatment, interruption rates were quite substantial. So 67% of people had some form of interruption in their treatment. Of those who did not have a recurrence and who did not die from the disease or other causes, about 33% of them discontinued the therapy before the intended duration of 5 years. So these numbers are sort of on par with some of the numbers Dr. Morgan mentioned previously. And I think it's important for us to just sit with these numbers and recognize how this really important therapy is being, somewhat underutilized, even in places where that might be one of the only things that they have. So as a result of that study, we did some assessments amongst the patients that we had, and it was a mixed methods assessment, including some surveys and also some interviews with patients, sort of understanding some of the challenges that they have in continuing the breast cancer treatment. So this slide I put up here sort of gives you a sense of some of the real practical transportation challenges that patients have. So you can see on this map, I don't know, actually, I don't think you can see my mouse. Anyways, on the map, all the way at the top is where the hospital is. That's Butaro Hospital. And in the middle is the capital, which is Kigali. And at the time that we had collected this data, patients were able to get endocrine therapy either at the hospital in the north or in Kigali in the middle. And we asked patients how long it took them to get to us, and the median travel time was 7 hours, and also quite a substantial cost for someone from Rwanda. We also looked at how the adherence measures differed depending on where the patients came from. So whether they were in the northern province where the hospital is versus, or in Kigali versus in other provinces. And as you can see, there were differences there were higher rates of non-initiation, higher rates of interruption, and higher rates of discontinuation for people coming from other provinces, sort of indicating that perhaps the challenge of transportation is quite important. We had also asked from patients' perspectives which things they considered as challenges in them sticking with their care. And I'll just talk about the first three. So challenges about them really understanding their treatment or the purpose of treatment, challenges around treatment duration, as well as challenges around treatment side effects. And all of these things are quite important and prominent, especially in treatment that you need to be on for an extended period of time. So that sort of led us into thinking about ways of potentially addressing some of these challenges. So I'll change gears briefly and talk about a project we did on enhancing biomarker analysis. So I'll go through this real quickly. And then the next set of slides would be about specifically around helping with adherence and addressing some of the challenges that the patients had mentioned. The breast cancer diagnostic pathway, at least in our context here in Rwanda, many times it is basically a 3-day process, not necessarily 3 consecutive days, but requires the patient to come to the health facility on 3 separate days. So the first day is sort of the day where the patient has a consultation with a clinician, and many times they're either referred here because there's already a high suspicion that the mass is breast cancer, or they were identified at an early detection campaign or something like that. And then sometimes the biopsy happens the subsequent, like the actual next day, or sometimes the patient might have to come back in a week for a biopsy. And then there can be a variation of time between when the biopsy happens and when they get their diagnosis. What happens after the biopsy is obviously the basic pathologic diagnostic workup, which includes H&E staining, and which tells you whether or not there is breast cancer. But then further biomarker analysis, which tells you what the subtype of breast cancer is. And in this case, what we care about is it ER positive or PR positive, and will they qualify for endocrine therapy? So the process for the patients is long. The process in the lab can also be challenging. And I think for many of you who have worked in lower resource settings, you recognize that challenges with expensive reagents, supply chains, and also the need for highly skilled technicians. Although it's not necessarily a complex process to do immunohistochemistry, and this is a technology that has been around for a long time. It is, in fact, quite challenging to consistently do. There have been studies from sub-Saharan Africa that have shown that in some places, greater than 50% of the cancer centers don't have access to consistently do biomarker analysis. And places that do have access many times have a lot of supply chain challenges. So this led us to think about evaluating an alternative system of perhaps doing biomarker analysis. And this system that we were introduced to, it's based on a platform called GeneXpert. And for some of you who might be familiar with GeneXpert, it is a platform that is available in many LMICs for TB diagnostics and infectious disease diagnostics. What was unique about this specific platform is it is an existing platform, it's a platform that utilizes a molecular semi-automation to be able to amplify and synthesize the DNA and also do the measurements all within one cartridge. And it was a system that had already been evaluated in high-income countries in the US and Europe, and it was highly concordant with the results from immunohistochemistry. So I'll describe the results of a study we did in Rwanda where we evaluated this technology. We did an evaluation to see how well it would work in our context, as well as an evaluation of cost. In order for us to do the evaluation, I guess just basically saying we're making a comparison between GeneXpert and immunohistochemistry, and what we hypothesized was this will potentially require less personnel time, and also will require less reagents, and perhaps would potentially be cheaper than the routine system. So in this study, we tested 399 tissue samples, this gives you a flow of the testing that we did. The test is called STRAT4, so STRAT4 testing, and then compared the results with immunohistochemistry. Here is just a high-level summary. I'm showing that in our context in Rwanda, the percent agreements between immunohistochemistry and STRAT4 was quite good. So 95% agreement or concordance, a specificity of 96%, and a sensitivity of 96%, and a specificity of 92%. Here's just a graph a visual showing you the agreement rates based on the level of ER staining. So on this axis, less than 1% ER staining is considered negative, 1 to 9% is considered low positive, greater than 10, 10 or greater is considered positive. You can see that here there were some false positives and here some false negatives. But for the most part, it was able to really differentiate, which aligns with the sensitivity and specificity I mentioned previously. I'll skip through some of these slides quickly, but this was the process that we went through to make an assessment of a cost analysis. And we utilized a complicated process called TDABC, which involves doing a process mapping, doing some interviews, both with patients and with to collect some data on costs, as well as mapping out exactly how patients and tissue pass through the system. So here's a complex process map, which I won't go through, but just giving you a sense of what we did to assess the cost. And what we arrived at was, we basically assessed the cost of the entire breast cancer diagnostic pathway at this hospital. And the cost of the entire pathway was $138. And of that cost, 49% of that was for biomarker analysis. So giving you a sense that although what $138 might not sound substantial, in the context of Rwanda and in many other low resource settings, that can be quite a burden, and recognizing that a lot of that burden is really from biomarker analysis. We also made a comparison between immunohistochemistry and Strat4. And for the biomarker analysis component, Strat4 was estimated to be slightly less than the routine cost from immunohistochemistry. And doing an analysis of how much time. So although the cost savings were modest, it actually required a lot less personnel time. So a lot less time from the pathologist and a lot less time from the pathology technician. Here is, I present this sort of as an example of how, potential innovative molecular platforms can be utilized or implemented, not necessarily just Strat4, but something that is that is based on a system that is already in use, can potentially be utilized to improve the biomarker testing. So next, I will talk about some strategies we've utilized for increasing access to endocrine therapy. So I set this up by, giving you a sense that patients were traveling quite long distances. Imagine having to be on this medicines for 5 years and having to travel 7 hours each time to refill your medicine. And the strategy of the process previously required patients to refill their medicines every month. So even though they might not necessarily have been required to see a clinician, the setup wasn't friendly for them to get their medicines in line with what Dr. Morgan had mentioned previously. So this project involved trying to decentralize the refills of the medicines from these 2 sites, but also to other provincial sites in Rwanda, as well as trying to give people longer durations of prescriptions such that they didn't have to come on a monthly basis. So our decentralization pilot involved first doing some training of doctors and nurses at the satellite clinics, but also required having a central liaison to help support and track patients, as well as involved patient education and enhancing the type of patient education we're giving patients. So this is an example of the tamoxifen information packet that we made for patients who were decentralized. So briefly, I would just show you that over the first 2 years of this decentralization, so these are the number of refills that happened at the satellite sites. You can see that we're able to maintain a substantial amount of patients being decentralized over a 2-year period. And I'll switch gears to the last part of this talk, which is around some of the strategies for potentially improving the adherence implementation, how patients are actually taking their medicines. And I'll describe to you a study that is ongoing to help us learn a little bit more from our population. So just re-emphasizing the different elements of the concept of adherence, and in the next few slides, what I'm really talking about is the implementation and how patients take their medicines. So I don't have time to really go through this conceptual model, but basically just it's describing that the behavior of patients taking their medicines is quite complex, and there are multiple things that can feed into that. So part of this is what information does the patient have about the medicine? What information do they have about the side effects? What are their personal motivations and what are their beliefs? What are some behavioral skills aspects that they have? And all of these things really feed into what patients do. Obviously, for this scenario that we're talking about, patients' adherence behaviors do impact what the health outcomes are, as shown by Dr. Morgan in the previous slides. So we did a review of the literature because unfortunately, within LMICs, there isn't actually a lot of data really telling us some strategies for improving adherence implementation. So we were looking in the literature across LMICs in general, after screening a variety of abstracts and full text, we arrived at 60 articles. 52 of them had some form of measure of adherence, while only 8 of them actually had some adherence interventions. And the factors that were described that were related to poor adherence were medication toxicity, financial burden, forgetfulness, and treatment duration. And these really aligned with what we saw in the survey we had of patients in Rwanda as well. The most common interventions that were evaluated were patient education, reminders, and simplified dosing of the medicines. And I'll say there were only 8 studies that evaluated adherence interventions, and most of them were really looking at short-term adherence. And this study wasn't just about endocrine therapy. This was looking at some anti-neoplastics across LMICs. So this sort of fed into this trial, which we're currently doing. And this is a trial trying to assess multimodal intervention, or multi-component intervention, and comparing it to what we're considering our standard of care currently. So this is a study that we're doing on patients with non-metastatic breast cancer who are relatively early in their journey of initiation of endocrine therapy. And we're randomizing them to the standard of care, which is the education booklet that I mentioned, as well as this is agnostic to whether or not the patients are participating in the decentralization. And the intervention here is a combination of video patient education materials, a way of patients to monitor their symptoms, so a symptom monitoring card that they can use to facilitate conversations with the clinical team. And in addition to that, weekly motivational text messages, just encouraging them to take their medicines. So in this study, we're also going to be looking at short-term adherence. So measuring adherence measuring adherence after 3 months, and then measuring after 6 months as well. I don't have data to share with you, but this is something that we're currently doing. So this takes me to my conclusion slide. So optimizing the use of endocrine therapy is a potentially high-value strategy for reducing disparities in global breast cancer. There are gaps in diagnostics. So gaps in diagnostics, structures of care delivery, and patient-related factors all contribute to the underutilization of endocrine therapy. And a multi-pronged approach multi-pronged approaches are required to really optimize the use of endocrine therapy. And this could include novel technologies, care decentralization, as well as rigorous ways of evaluating the intervention. So thank you.
Thank you. Wonderful. So a couple comments here. I'm going to go from the chat. So the one thing I see, the last one here, is it interesting that most of the cancers in Rwanda were hormone receptor positive. In Nigeria, they see a preponderance of triple negative disease. And I think that's been studied in the literature to that increasing triple negative breast cancer. I don't know if Dr. Fadelu, you have a comment on that.
I think it's it's complicated, and the reason I say it's complicated is because the results of endocrine therapy tests in immunohistochemistry is affected by how the tissue is preserved. So in the Rwandan context, we've also seen that when the tissue is not appropriately preserved, it can come out as being triple negative. So I'm not sure I'm entirely convinced that the rates of triple negative disease are as high as some of the studies indicate. I think there might be some confounding with regards to tissue preservation. And I think that's another thing to sort of think about in appropriate diagnostics.
Great. And then Dr. Fadelu, there's another question from our global breast surgery fellow, Dr. Hamid. Is there a team willing to train pathologists and LMICs in the methods of using GeneXpert for receptor studies, for example, via Zoom meetings? And have you explored this?
Well, that's a great question, and unfortunately, it's also a bit of a complicated question. So, GeneXpert. The study we did was utilizing it for research purposes. So it wasn't. We were comparing it with immunohistochemistry. So we haven't yet implemented the use clinically. And the reason why it's complicated is because the GeneXpert is technically Strat4 GeneXpert is technically not yet commercially available in many countries. And it's also not entirely clear that it may become commercially available for complicated reasons with the company. But if at some point it is commercially available, I think there's certainly ways of training in the use. So our pathologist in Rwanda who led the study was able to get trained by Zoom with the company. And this study, we started this in the middle of the COVID pandemic, so there was actually not a lot of travel. Yeah, so it was relatively easy for the pathologist and the technician to get trained by Zoom. So it is the conventional machine. It's just a different cartridge. So some of you might be aware that the machine can also be utilized for CML diagnostics as well as ALL diagnostics. So basically, it's able to measure abnormalities or changes, differences in genes. It's somewhat agnostic to whether it's a TB gene or a breast cancer gene or whatnot, but it requires a dedicated cartridge for the specific use case. Yeah.
Think Desta, this next one is which group of patients should we give extended adjuvant endocrine therapy A lot of the studies use women, the more recent studies use women of high genomic risk. So using these very expensive assays, Oncotype, MammaPrint, to see if they're genetically high risk. They have these metastasis genes, but that is not available throughout most of the world. And so we use clinical risk as a surrogate, which has not mapped exactly onto genomic risk, I would say. So when we have to proceed with some caution in places where women do not have routine screening, so they present with advanced disease. But I would say women who have stage 3 disease and have positive nodes or high-grade tumors, if you can look at the grade, I think generally, and are premenopausal, those women are at high risk, and I would consider those for 10 years of endocrine therapy. And then what are my experience regarding side effects? It is such a journey with these patients, and the side effects, the hot flashes on tamoxifen can be quite debilitating. There are a lot of common drugs, though, that can help. I think number one, it does get better over time, especially the hot flashes. But gabapentin, oxybutynin, those drugs can help a lot. If you do have venlafaxine, some of those like kind of TCA antidepressant drugs actually have hot flash properties, but gabapentin is the most common one, and I think a very common drug that can help with the hot flashes. For osteoporosis, using drugs like bisphosphonates every 6 months for 3 years has helped to reduce the risk of osteoporosis and has shown improved breast cancer outcomes. So women have reduced risk of distant recurrence in the bone when you use things like Zometa, the bisphosphonates, so that's zoledronic acid. So I'd say there's a lot. We could probably do a whole talk on managing side effects of endocrine therapy, and we could do that if people really desire that. Because there are, I think, many avenues we can take with that. I hope that answered the question. And then Adeni, I hope I'm saying your name right, I think made a very good point that it's really important that stage 3 patients are not actually stage 4 because of inadequate imaging studies. Many oligometastatic tumors are being seen with improving availability. Thus, standardization of the staging has to be done. And I'm not sure of the process in Nigeria and Kenya, because there's no screening, and most women are at least stage 2, and majority stage 3 who have localized disease, they're all getting staged with CTs. I'll be interested to hear other people's practice if they're staging every woman with localized breast cancer. I don't know if anyone else has comment, or Dr. Fadelu, what they're doing in Rwanda for staging for localized breast cancer.
Yeah, I think unfortunately, it has more and more people are presenting earlier, but still a substantial number of people present with quite substantial disease. And in a way, irrespective of whether they're oligometastatic or frankly metastatic or stage 3, they will still all benefit from having endocrine therapy. So I think sort of the importance of endocrine therapy is certainly not diminished, even if it's just not technically adjuvant, but it's still something that they would benefit from. Yeah.
And then Hanu Tesso raised their hand. Do you want to go ahead and share your comment?
Okay, thank you very much. This is Brown talking from Ethiopia. Like said in the presentation, endocrine therapy is one of the therapies that is commonly used in all over the world to treat breast cancer. But the problem, especially in developing countries, is that the availability of immunohistochemistry staining is very low. So I remember when I was a resident training in general surgery, we saw a study which said that up to 85% of breast cancer in African Americans is hormone receptor. I don't exactly remember the study, but there was such a study. And what we did was we started to give this endocrine therapy for all patients who have breast cancer. So that was what was practicing, but we are practicing. But nowadays, this immunohistochemistry is becoming available, but still there is a scarcity of this staining. So what do you say about starting all patients with breast cancer who cannot, or when there is no availability of this immunohistochemistry? So can we start them all on endocrine therapy? So what do you say on this one? Thank you.
That's a good question. And I think that's what a lot of places end up having to do, is really give everyone endocrine therapy when you can't test. I think in most places, at least more than half of the patients are ER positive. So that's what many places do. And I think it's acceptable if you can't test. I think it would be helpful to have a sense of what the percentage or proportion might be in your population. But if you're not able to do that, then I think it's not unreasonable. So that's what a lot of places do. Yeah. Yeah. But
I think
also
finding
just recognizing that it's a huge burden on somebody who may not necessarily have needed it. Recognizing that you're committing someone to 5 years of treatment that they may not have needed. But yes, I totally understand that it is challenging. And I should mention that sometimes, so in our setting, if patients are not able to get tested on their biopsy samples, every effort is made to at least test them on the mastectomy samples after the disease is taken out or whatever. So yeah, there might be strategies of trying to maybe not necessarily test on every sample, but test on some things. But it's challenging.
Well, thank you both for outstanding presentations, and I want to thank our participants. Those are pretty high-level questions, and that made this discussion interesting, but also very pertinent. Our 10th seminar for the year is going to be April 4th. We will be talking about metastatic disease. Dr. Ragunwala will be talking about palliative care. I will be talking about surgery. If you have other thoughts for topics that would be interesting and useful to you, please let Dr. Morgan and I know, and we will try to get them added on. For now, and again, it's a little later than I wanted to go, but that's okay. It was worth it. So have a great day, everyone, and thank you to our panelists.
Thank
Thank
you.
you.